affected by the enlargement of that uterus. Okay, so they start putting pressure on the bladder, they put pressure on the rectum, all the connective tissues around it are going to be affected. And so as these females get pregnant and have more and more pregnancies, those surrounding structures, you can see the bladder, the rectum, and the connecting tissue have a high likelihood of ultimately being affected. Even with one pregnancy, there's a potential for those organs to be affected. So we want to think about that. So it can cause these pelvic floor disorders. Really, that means that the proper functioning, or the pelvic organs have lost the proper functioning. Okay? It can cause prolapsing of the organs, it can cause sagging of the organs, it can cause issues with bowel or bladder control, like we just saw in that cross-section. And then ultimately weakening of those surrounding muscles and the surrounding connective tissue. It affects about 1/3 of women, and of those 1/3, about 30% of those guys are going to need some sort of surgical intervention to help repair the damage that has been done, from a variety of things. So oftentimes this is caused, yes, by childbirth. Of course, it increases with the number of births somebody has, increased risk of pelvic floor dysfunction. But obesity can cause it. Obesity causes a lot of pressure on the pelvic organs. Someone who had pelvic surgery, anytime you have surgery on anything, the intent is to repair, but your tissues are never, your bones are never quite as strong as they once were. One of the things we deal with in the military is repeated heavy lifting. Now that new PT test for the Army, I thank God I don't have to take that one. I don't know if I can do it. Like that test seems really brutal. Is it as bad as it seems? No. I mean, you got to pick that ball up and above your head. My back hurts just thinking about that. Right? And how much does that ball weigh? Like 30 pounds? 10 pounds? So 10 pounds over your head. Like, who does that? I don't know. That's weird. And then some people with genetics, right? Some people are born with weak musculature. You will see this a lot more frequently in the military than you think, and probably even more so than we see outside of the military setting. These patients can come in, and their main complaint could be a urinary, like urgency, or feeling like they can't completely empty their bladder, but urine is negative, and know if it's infection, your culture is normal. They may have this sense of fullness or heaviness, not just in their pelvic or the perineal area, actually in their lower abdomen, like something is pulling down in their lower abdomen. Okay. They can have a bulge that they either feel or they can see in their vaginal area. And then sometimes they'll have just bleeding, which is that painful intercourse, or just easy pain with bowel movements, depending on the cause of their symptoms. So think about these pelvic floor disorders. We're going to think about those that are associated with pain or hypertonic dysfunction, and those that are associated with weakness, or support, weakness of the supportive structure of the muscle. Okay. So if a woman has hypertonic pelvic floor dysfunction, the muscles don't relax. This is going to be more common in younger folks, and so I say younger, 20s to 40s or so, and it causes pain even with basic things like I'm trying to go to the bathroom, I'm having a bowel movement, or even intercourse causes pain with that. The supportive floor dysfunctions, more common in older women, more common in patients that have had multiple pregnancies and multiple deliveries, and again that's caused from that stretching of the pelvic muscles and the pelvic connective tissue. Okay, so let's talk about initially about some painful disorders. Vulvodynia is a painful disorder, and it's considered more of a chronic discomfort that these patients may have, usually 3 to 6 months of pain, and there's no identifiable cause, meaning this is a diagnosis of exclusion. There's no other reason for this patient to have vulvar pain. The thing about vulvodynia is pain in the vulvar area, based on her physical exam, based on her history. It affects about 11% of women, and they will often come in complaining of this burning sensation or this raw feeling that they're having on either side of the vulva, in the vulvar area, labia majora, typically. It can be associated with things like biking, sitting for a prolonged period of time, or even sexual intercourse can increase their pain. Some patients will have it specifically get worse around the menstrual cycle, so it's important to ascertain in their history if it's affected by the menstrual cycle or what time in the month this pain typically increases. And then a lot of these patients have some other chronic pain disorder, something like IBS or fibromyalgia. They may have things like TMJ. They often call them named vulvodynia. So on exam, we typically don't find anything obvious. Okay? So there's no vulvar erythema, there's no vaginal discharge. So if you don't see anything obvious, then what the recommendation is to do is something called a cotton tip applicator test. So you take a CTA and then you do mapping all around the labia majora, all around the vulvar area. And you're trying to identify if they had any pain at all with that mapping. So you do a 360 around there. And even in patients that we don't physically see any pain, once we send them to a specialist, about 60% of those patients, once seen by the specialist says, no, this is specifically related to some sort of dermatosis. So unfortunately, we may not see a physical abnormality because of all the treatment. We have to send them to the specialist, and the specialist does some special testing on them and determines that in fact it was related to dermatosis. So it's nothing you did wrong. Sometimes it's just hard to see. Okay, so how do we treat this? About 1 in 10 patients, it's just going to go away. So oftentimes what happens is they wake up one day, they start having this vulvar pain, it lasts for months and months and months, and then they wake up another day and it's gone and never comes back. That's 1 in 10. Otherwise, it's typically going to be a multidisciplinary approach. Vulvar care, which we'll talk about in a minute, pelvic floor physical therapy, because there is an association of weakness with this as well. And then medications. Okay? TCAs are going to be your first line medication. Okay? You can try SNRIs, okay, if the TCAs don't work. There's nothing wrong with adding topical lidocaine or topical gabapentin or even oral gabapentin. Sometimes with a gabapentin, you can just give it to them at night and it will help with their symptoms throughout the next day as well. So vulvar hygiene, this is what we're talking about. So really, behavioral therapy, vulvar care, talk to your patients about wearing tight-fitting clothing. Okay? We talked about that before with the Lululemon pants, right? We love those pants. But make sure that they're changing their undergarments. Make sure they're not constantly wearing this tight-fitting clothing. Now, avoid douching. Be careful with feminine hygiene products that have that smell good, or even laundry detergent that smells good. Sometimes that can cause irritation and cause increased chance these patients get vulvodynia. Okay? So the other thing is when we do your exam, the first thing we want to do is try to identify, do I see some obvious abnormality? Is there redness there? Is there discharge? If there's redness or inflammation, especially in one focal area, this might be something like a contact dermatitis. Okay, we talked about that. This might be an allergic dermatitis that's causing that. If there's an obvious abnormality on physical exam, we're going to address that. If there isn't, now it's time to do that cotton test testing. If that cotton test swab testing is negative, and this is probably not vulvodynia. Vulvodynia, we're going to have that positive cotton test, at least for our perspective, before we send them to the specialist. If it is positive, the recommendation is still to do a yeast culture. So you can do your swab and swab externally, and then also swab internally and send it off to evaluate for yeast. Okay? Because again, maybe they do have candidiasis. Maybe it's not externally where we can see obvious redness, but if they have candidiasis and they're holding that in their vaginal vault, then, you know, throughout the day, that's gonna come out and then get on the vulvar area. So we're gonna swab for that. And if that's positive, you're gonna treat. Otherwise, if that's negative, now we're gonna go over to our vulvar care, we're gonna try our medication. And then ultimately, these patients may end up with, you know, going to surgery and they can do like a vulvectomy. And nobody wants a vulvectomy, right? We saw that when we talked about vaginal cancer. Well, they'll remove the entire area of the vulva that's affecting this patient. And that can cause, obviously, some long-term issues with scarring and other complications. So that's all we need to know for vulvodynia. Vulvodynia is going to be pain in the vulvar area. We're going to do that cotton test, swab testing for these patients. We have no obvious physical exam, not nice. And then TCAs are going to be our primary for treatment. Now let's talk about levator ani. So we know that levator ani, that's the main pelvic floor muscle. It consists of the pubococcygeus, the iliococcygeus, and then the puborectalis muscle. So these patients oftentimes will come in with these spasms of pain, so sudden onset of pain. Usually it's going to be in the rectal area because that's where the main location of those muscles are. Okay? So they'll have rectal pain or pressure, comes on all of a sudden, can last for seconds to several minutes, usually less than 20 minutes. It occurs day or night, does not seem to be affected by bowel movement. So it's not associated specific with bowel. Can they have the pain when they're having bowel movement? They certainly can, but it would just be coincidental. It's not that the bowel movement is bringing them on. Oftentimes they will have other associated signs and symptoms as well. Dyspareunia, chronic constipation, lower abdominal pain or pressure, or even sometimes low back pain because of the muscles. Those are very large muscles. When they spasm, it's going to pull on that low back as well. Affects about 7% of females mid-age from 30 to 60 years old. So the ultimate treatment goal for this is to reduce those spasms, to reduce the trigger points that these patients are having. We can do that by sending them for physical therapy. There are people that do trigger point massages, okay, or what we call ischemic compression. And so what ischemic compression is you're actually taking your finger into the vaginal vault. You're using your finger to go along the posterior portion of the vaginal vault, and you're identifying what area is bothering that patient. Once you identify it, you're going to press fairly firm on that area. And what you're trying to do is decrease blood flow to that area and break that spasm to make it go away. Okay? So they'll get that done repeated times, and ultimately that can treat the levator ani syndrome. Psychotherapy with relaxation techniques, because again, this is muscle tightening. So we can send these patients to psychiatry and psychology. And then medications, analgesics. So we don't want to use opioids because this is a great way to get someone addicted to opioids, right? Analgesics, we're really talking about probably more like acetaminophen, higher dose acetaminophen. You can use antidepressants, it doesn't matter which one. And then sometimes muscle relaxants can even help, especially if you give them to them at night. It'll help them sleep better at night. If they're sleeping better, it'll reduce their episodes during the day. If that doesn't work, it's time to refer these patients, and they can do dry needling. Trigger point injections can be done. That's usually done by pain management. And then pain management can also do Botox injections if they're unresponsive to the dry needling treatment point medications. And that's it for levator ani. Biggest muscle that we have in our pelvic region, rectal pain. Not associated with bowel movements, can occur day or night, and it's sudden onset of these spasms of pain. And then we have pudendal that's also a painful pelvic floor disorder. The pudendal, we want to know that it's the main, provides most of the innervation and sensation to the pelvic region and the external genitals and the anal region as well. There's 3 branches that comprise the pudendal nerve, and that is the dorsal nerve clitoris, which is going to cause clitoral pain if it's affected. Okay, the perineal nerve, which will cause pain in the vulvar area if it's affected, and then the inferior rectal nerve, those patients will come, just like they're doing letter E and I, will come with rectal pain. Now, they can have involvement in any of these, so it could be one or it could be all, and it can be intermittent. One day it might be I have clitoral pain, the next day it might be I have rectal pain, so it could be any form or fashion. We don't see this very often. Less than 1% of the patients that we see are going to have this. Oftentimes when they do come in, it's going to be a unilateral. So it's not going to be a vulvar pain on both sides. It's going to be a unilateral pain. So if we have diffuse vulvar pain, we're thinking more vulvar 99. A diffuse rectal pain, we're thinking more lever 89. Here, like it just seems like one area is being affected. And the other thing with this is that pain worsens throughout the day. Okay? Oftentimes brought on by things like prolonged sitting, okay? Repetitive hip flexion, jogging, cycling, a stair stepper, something like that. Even bicycling can cause this. If someone had any sort of pelvic surgery or a pelvic fracture from trauma, they are at risk for preventive neuralgia. And then vaginal delivery, so pregnancy and vaginal delivery, they can have some, that's certainly trauma to the birth canal, and it can be trauma to that nerve. I saw a lady not that long ago that had this, and it was after she was completely fine, and it was after her first vaginal delivery that she had this, and she was terrible pain. And then the other thing they may have is chronic constipation. So some of these signs and symptoms will appear like lever ani. So make sure you kind of pick out some key things. Rectal pain wouldn't necessarily be a key thing. The fact that it comes on throughout the day. The other thing is that there's no associated sensory loss with this. So we have these non-taste criteria. Of those non-taste criteria, no sensory loss. Worse with sitting, does not wake patient up in the sleep. Lever ani, day and night. Okay, so pick out the things that are different for these for the SSA examination. And then for our non-test criteria, we've got to think about things that follow that within pathway. Okay, and so unilateral vulvar pain, that is very concerning for preventive neuralgia. And the other part is relieved by nerve blockade. That's not simply usually something you guys are doing unless you're in workup management. So treatment, we're going to start with our conservative therapy. If we feel like sitting is the problem, use a standing desk. Right? Oftentimes the recommendation is to use a donut if you're going to sit. And it changes where the pressure points are. Right? Instead of the pressure points being in the perineum, it's going to move out to the ischial. Avoid those exercises that make things worse. So avoid running or cycling or rolling or stair stepping. That's what makes this thing work. Gabapentin, the oral or TCAs, that works okay. Physical therapy, the majority of these patients are going to need some sort of physical therapy. Physical therapists are amazing. They'll typically take these patients into a room and they'll do special tests and special interventions to help them strengthen up their pelvic floor. So we talk about, most of you guys know about Kegel exercises. This is well beyond the Kegel exercises. And then again, from our pain management folks, something like a nerve block might work, and they do Botox injections of that nerve every few months. If all of that is unsuccessful, then the last thing would be surgical intervention. So we start with conservative management initially, and then cervical nerve decompression if there's evidence that the nerve itself is compressed somewhere. Okay. That is it for that. We'll talk about dyspareunia. We talk about dyspareunia a lot in general terms. Dyspareunia is painful intercourse, and it happens to up to 60% of women, but the majority of women do not seek treatment because they understand that they feel like this is probably a part of life, that this is going to happen. So sometimes these patients will come in and they'll say, yeah, it hurts, but I'm still able to do pretty much everything. I can still have intercourse on a routine basis. It doesn't hurt, so much so that I can't do it. Other patients will come in and say, look, this bothers me so much, I can barely do anything. If I have intercourse at all, any penetration, I have significant pain, so I can't even do that. Oftentimes, not only do they have pain with intercourse, these patients can have associated vulvar pain, neurogenic complaints, we have numbness and tingling. And then this is somewhat considered to be a component of a psychologic disorder as well. So much so that they created a DSM-5 diagnosis for this, genital pelvic pain and penetration disorder. So although it may not have stemmed from a psychological disorder, if someone has pain every time they have penetration, it can certainly cause that. So there are different classifications associated with dyspareunia. We have primary dyspareunia, that is pain with intercourse from the very beginning. Ever since I started having intercourse, I started having pain. So patients that have primary dyspareunia, you want to think about kind of the worst case scenario. Genital mutilation, sexual assault when they were younger maybe, or even maybe congenital anomalies. If you remember back to our very first lecture, we talked about a young lady that came in, she otherwise looked like a normal appearing female, had no external genitalia, but had pain with intercourse, and ultimately she was diagnosed with Mayer-Rokitansky Hauser syndrome. She didn't have a uterus, she had a Mullerian dysfunction, right? Dysgenesis. She didn't have a uterus, so she had pain with intercourse. You want to think about that for patients that come in with primary dyspareunia. We have secondary dyspareunia, meaning I was fine for a while, and then I started having pain with intercourse. And there's a lot of different causes for that. Even, we think about endometriosis. We know that as a common cause. Leiomyomas can cause that, depending on where they're located in the uterus. Scar tissue can cause that as well. These patients can have generalized dyspareunia, but I have pain no matter what. Doesn't matter what the position is, doesn't matter when it occurs. Anytime I have intercourse, I have pain. Or it can be situational, only with specific positions, only with specific partners. And then we have these sub-classification of dyspareunia. So there's superficial dyspareunia. I have pain only with the initial entry, only with that. Think about vulvodynia, because that causes spasms of the vulvar area, vulvitis or inflammation, or even sometimes poor lubrication, especially if someone's kind of perimenopausal or postmenopausal. Patients can come, another subclassification is that they have pain only with deep penetration. Fine, as long as there's no deep thrusting. Endometriosis, pelvic adhesions can cause that. Again, leiomyomas can cause that as well. Unfortunately, a lot of these women will come in and they'll have pain with both deep and superficial penetration. Other causes to think about: infection. And that's why we do physical exams on these patients. Look for evidence of vaginal discharge. Look for evidence of, do they have irritation of their vulvar area. There's nothing wrong with these patients doing a cotton swab test, and you'll see if that's going to be positive. These patients have had multiple vaginal deliveries. They have episiotomy scars that can cause pain and dyspareunia. If they have other psychological disorders, chronic pain disorders, chronic depression, that will increase their risk. And then evaluate these patients for a hypoestrogenic state. So things like someone just delivered their breastfeeding. Immediately postpartum, they're in a very low estrogenic state. And so they're going to have decrease in estrogen, decrease of lubrication. So you want to probably promote to these patients to use lubrication for their first 7 weeks after delivery, and that will help reduce the amount of pain they're having. Of course, perimenopausal, postmenopausal patients are going to have vaginal tissue atrophy. That's going to look more pale and thin, decreased lubrication. So those patients, we're not talking about maybe things like estrogen treatment. On exam, you've got to look for that generalized erythema in the vulvar area. Look for the episiotomy scars. Look for that atrophy, which is that thinning, and that the vaginal mucosa also appears to be pale. You can even look for things like excoriation, where they're having chronic itching. Again, erythema, but that may be something like candidiasis, that may be atopic allergic dermatitis, or a focal infection. If they have any sort of discharge, I would take a swab and send that off to lab. Vaginitis panel, vaginosis panel, so look for KOS aircraft, looking for yeast, looking for bacterial vaginosis, looking for trichomoniasis as well. GC chlamydia in the right setting with the right patients. Okay? And then if they have vulvar pain, we're going to pull out that cotton tip, the cotton swab, and do that cotton swab test and run that, those painful areas to see if that kind of helps. Evaluate the gland. Remember, you got the periurethral glands, which are going to be up next to the urethra, and then we've got the Bartholin glands. Make sure you're not missing some sort of Bartholin cancer, okay? Because these patients may not even know they have a little swelling down there. And then the examination itself. Typically, what's recommended is you start with a single digit examination. So one finger in the vaginal vault, kind of push back towards the rectum, okay? And what you're feeling for, it is not unusual for women to have initial kind of vaginismus, so they have tightening around your finger. That is expected. Okay? That's just kind of a reflex. But that should only last for a few seconds. Okay? So those muscles should alternately relax for a few seconds. It's maybe sometimes 10 or 15 seconds max. But if you feel that that's continuing to be tight, then that is concerning that they have persistent vaginismus, which could be the primary cause for their dyspareunia. Okay? So once you can get beyond that initial contraction, everything relaxes, then you'll first insert your finger a little deeper, feeling along the vaginal wall, so you feel the anterior wall. If they have pain up on the top portion, up where the bladder's at, that may be something like interstitial cystitis. You're pushing on the bladder, it's causing irritation on the bladder. Okay? If you go with deep penetration with your finger and they're having pain with that, again, things like endometriosis, you want to do a very staged approach before you even do your speculum exam. Because once you do your speculum exam, if these patients have pretty significant dyspareunia, you're not going to get much out of the visual exam. There's going to be too much discomfort needed in performing that exam. Treatment is going to depend, of course, on what we can identify as the cause. Usually, it's going to be a combination of things. So if we think it's vaginismus, so the vaginal vault, the external vagina, the muscles are constantly tight. Physical therapy can do structured desensitization. And what that is, they will use vaginal dilators of different sizes, and over a period of weeks, they'll insert these different sizes of vaginal dilators and kind of get the patient's mind and body used to the larger size of the dilators. That's almost always done in conjunction with counseling. And then again, if it's a poor lubrication problem, we talked to you about using lubrication methods. Even petroleum jelly works okay. If it's hypoestrogenic state, maybe some topical estrogen is okay. If we can identify on exam that there's a structural abnormality, so maybe this person has had a couple of episiotomies, they'll have some pretty significant scarring, and these patients may need to be referred for either adhesion or ablation of the scar tissue or lysis of the scar tissue. If we think that they need a problem with their anatomy, they need to have restoration of their anatomy, that's all done by the surgeon. And if we think it's endometriosis, because they in fact say, I primarily have with deep penetration, and oh, by the way, I have some of these other V's, and we refer them for laparoscopy. We know that referring for laparoscopy is both diagnostic and therapeutic because they can treat, they can evaluate, and treat at the same time. All right, let's move on to interstitial cystitis and painful bladder syndrome. So again, another painful cause of pelvic pain. These patients, these are actually two separate entities, but they have a lot of overlapping features. We'll talk about some overlapping features first. So chronic pain in the bladder, or chronic bladder pressure that's lasting at least 6 weeks or more, can affect up to 3% of women. And typically, this is seen more often in women in their 40s, white females who smoke. Okay? And they're not exactly sure why people get this, but the thought is that there's a a sensitivity for these patients to histamine and histamine release. These patients oftentimes will have a defect in the mucin layer of their bladder, and this histamine gets released, and so things like alcohol or caffeine or smoking or even fruit juices, that can cause an increase in the histamine release, and it will irritate that bladder that's already has some structure out now as the mucin layer, the defect of the mucin layer. So again, strongly associated with these patients that have interstitial cystitis, oftentimes they have other chronic medical conditions. Endometriosis, fibromyalgia, generalized pain disorder. They oftentimes will also have other pelvic floor disorders like vulvodynia or levodopa syndrome. They can have chronic psychological disorders as well. When these patients come in, they've got this pelvic pain or these bladder symptoms, and we really work them up, and there's no other cause, and this is one of the things that you think is your main cause. So again, two different entities. We have interstitial cystitis and painful bladder. So interstitial cystitis, urinary frequency, urgency, pelvic pain. Both of them have that. But for interstitial cystitis, it's actually going to be a physical exam, not for our physical, but for neurology. They'll do a cystoscopy, and they can actually see abnormalities inside the bladder. For painful bladder syndrome, they're not going to see any. They'll do the cystoscopy, they will not see any obvious abnormalities in the bladder. And then the bladder capacity. So bladder capacity is how much that bladder can hold. For interstitial cystitis, it's going to be reduced. And for painful bladder syndrome, it's going to have normal amount of bladder, so no bladder reduction in capacity. So how might these patients prevent? They're going to present like they have a urinary tract infection. Frequency, urgency, nocturia, get up 3 or 4 times in the middle of the night. Okay? Pain, as their bladder fills up, some of these patients will have pain at that point. I'm okay until I can feel when my bladder gets full, and I really start to be very uncomfortable. Oftentimes gets better once they urinate, the pain resolves. Urinalysis, negative for infection. Urine culture, normal. And what I have seen is, sometimes we get a little lax in our workup for these patients, and repeated time after repeated time, these patients come in, I've got these symptoms, it's probably just a urinary tract infection, let me give you antibiotics. 6 weeks later, let me give you antibiotics. Let me give you antibiotics. But no one ever does the workup, so be very, very careful in doing that. Do a urinalysis for a couple of reasons, but mainly we want to know about infection, but also make sure they don't have anything like hematuria. And hematuria is not normal, and those patients will need to be referred. Again, sometimes these patients will have increasing symptoms premenstrually, so ask them about when their symptoms occur primarily, and if it seems to occur on a calendar just before the menstrual cycle in that late moving phase. There's a lot of different triggers. We've got alcohol, caffeine, we talked about that, spicy foods, fruit juices. So a lot of times if someone comes in, they have urinary tract infection, I'll say, drink some cranberry juice. But these guys drink fruit juices, it actually makes it worse. So if you talk to someone and they're like, yeah, I've tried that, but man, it seems like it makes it a lot worse, that would be your clue as well. Like, why would that be? And the reason, do you know why, by chance, fruit juice or cranberry juice specifically might help with if someone has a GI? Yes, it changes the acidity as well of the urine. Changes the acidity of the urine. On the exam, a lot of times these patients will have tenderness around the urethra, or on the single digital exam on the anterior, but the top portion of the vaginal wall, you're pushing against that bladder, the base of the bladder, and they'll have pain that's associated with that. They can have hypertonus, and you insert that finger, everything kind of gets tight like a vaginismus. Okay? Or they may have trigger points that's associated with that as well. Urine culture need to be done, and those would typically be normal. Again, if they have hematuria, especially in a smoker, they have to be referred. They have to be referred. I tell you guys about my friend So I have this guy, I think I told you. Did I tell you about a guy that I knew that ran like 30 miles a day? Well, I'm gonna tell you. If I told you, just tell me. But this is my friend. Now he's getting ready to retire. He's a PA, smart dude, really, really smart dude. I've trained him ever since he was a baby PA. And I was replacing my shift one day, and he's like, I peed blood today. I'm like, okay. What patients do you have? He said, no, listen to me, I peed blood today. He's like, because he's a Delta guy, so he's like, I have run 30, 40 miles. I've never peed blood in my entire life. And today, I had gross blood that came out. And he happened to have a urology coming down to see a patient for him and talk to urology. I was like, yeah, come on up and see me next week in the clinic. And he had bladder cancer. Bladder cancer. Peed blood one time. He said, I've never peed blood in my life. Now, maybe he had microscopic, which is what we're trying to catch, right? So microscopic hematuria, I'll give you 2 chances to miss it, right? The first one, you'll be like, we just did heavy PT, maybe it's that, come back and repeat it in a week, okay? And I'll give you that. But other than that, look at their risk factors and just, it's better just to send it, to be honest with you. You don't want to miss that. You don't want to miss bladder cancer. And if there's something in their lab that said there was blood in the urine and you did nothing about it, you will get sued and you'll lose. So make sure you have that. All right. So how do we diagnose this? It's hard. It's really difficult. We're going to go on their signs and symptoms. We're going to go on the fact that their urine and urine culture are negative. And oftentimes it's going to require a referral to urology at some point. They will do a cystoscopy. And what they'll see in the bladder is what we see here, these ulcerations, these Hunter ulcerations. That's usually diagnostic for interstitial cystitis. And they'll treat those. They can actually use like electrocautery and treat those areas while they're in there doing cystoscopy. Again, neurodynamic studies that is done by urology, that's not something we do, and it shows decreased bladder compliance and capacity for these patients. First line treatment is behavior modification. Let's figure out if we can identify specific triggers and have our patient avoid those things. Spicy food, fruit juices, obviously smoking would be nice to get avoided. Second line would be physical therapy, and then medications. Almiron, I don't know that it's one of the first FDA-approved medications for interstitial bladder syndrome and painful bladder. And it works in about 60% of patients that take this medication. You can try amitriptyline, usually at bedtime, and that can help as well. Cimetidine, hydroxyzine, why does that make sense? It's a histamine. We think at least it's a histamine problem, right? So those are antihistamines. So they reduce the amount of histamine released, which ultimately may improve these patients' symptoms. And then what they do realize is this is not an infectious process, so don't put these patients on long-term antibiotics, right? Long-term corticosteroids don't help. They don't help. So although we aren't sure that a lot of things do help, we know that those things don't help. So don't try to use those things for these patients. All right. That's it for that. All right, now let's go. Chronic pelvic pain, like our last pain. Chronic pelvic. So all of those things we just talked about, they all have in common that they can cause this. They can cause chronic pelvic pain. Chronic pelvic pain can be caused by many, many, many other things as well. But it occurs in upwards of 15 and probably even more than that. But 15% of usually reproductive age females. According to the American College of Gynecology, chronic pelvic pain is non-cyclic pain, okay, so not associated with the menstrual cycle, lasts for at least 6 months, okay. It localizes, to the pelvic area or even the anterior abdominal, so even over like the suprapubic area can be affected. Lower back as well, so it could be any of those areas that are affected. And then these patients have pain that's so significant, it often interferes even with their daily activity. Okay? Doesn't mean they can't shower or do things, but even sometimes vacuuming the floor, picking things up, picking their children up, increases pelvic pain and pressure. So it causes these patients to have interference with their daily activity. Pathophysiology, again, there's a lot of things that cause it. We don't really understand exactly why people get focal pelvic pain, but oftentimes it's associated with other chronic medical conditions that we've talked about, many of these. It can be associated with interstitial cystitis, vulvodynia, irritable bowel syndrome, fibromyalgia, chronic pain syndrome, all of those things. Even people that have chronic reoccurrence, so we know migraines are chronic, but they get migraines all the time. They have an increased risk of having chronic pelvic pain as well. A lot of different causes, some of the main causes that we've talked about previously: endometriosis, uterine fibroids. You want to think about sexual abuse, sexual mutilation as well. Anybody that has a history of sexual abuse, they have a significant increased risk of not only chronic pelvic pain, but a bunch of those other chronic pain disorders as well. So you don't have to memorize this, obviously, but this is just kind of a short list of all the different things that can cause chronic pelvic pain. And this comes from Williams UNM, which is text structure that we use for this class. So again, as you are going out on your own after phase 2 and practicing medicine, these patients come in, this is why we give you this information. Okay, let me think about all my differences that there can be, and let me start figuring out how I'm going to rule those things out, either by history, physical exam, or by laboratory evaluation. So when someone comes in and they are complaining of chronic pelvic pain, you've got to ask a variety of questions. So you've got to ask them about when did it start and how often does it happen, what exacerbates. So all the things that you guys already know is really using your OPP QRST to some degree on these patients, right? To figure out, try to identify specific causes or things that exacerbate. Okay? And then on top of our history, you've got to do a physical exam. It's going to be usually things that's going to lead you to rule out those other differentials and give you down to 2 or 3 specific diagnoses of this would be. You want to evaluate this patient's posture. Look from the back, look from the front, look from the side. Look to see, do they have asymmetry of their anterior superior spine, the posterior area? What about their shoulder girdle? Are they kind of standing like this? That can cause, posture problems can cause a lot of pain in the pelvic area as well. There's something called a typical pelvic pain posture. You guys probably didn't know that was a thing. But typical pelvic pain posture is kyphosis and lordosis. So they're walk around like that, right? And usually if they're walking like that, they got a majority of those other chronic issues as well. So we want to look for that. Look to see how are they walking into the room? How are they walking into the clinic? And evaluate that. Are they, limping, intelligent gait? You want to do your abdominal exam. You're going to do a low back exam. You're going to do a pelvic exam on these patients. I would assess for hernia, which is really easy in females. You just put your fingers over, your hands over the femoral hernia areas and have them do a half sit-up up and put pressure on there to see if you see or if you feel any bulging in these patients. Once that's done, usually you're going to go into your GYN exam, and that GYN exam again should be more of a step-by-step approach. This is what we're going to do first. Do an external exam. Do your mapping from the cotton swab. Do your single digital exam slowly for these patients so you can figure out where their pain is located. Then, once that's done, you can do your spectral exam, and then most of these patients, it's recommended to do a rectal-vaginal exam as well. Because is this coming from the fact that this patient has some large hemorrhoids in the back, or, they have some rectal problem that's actually, maybe they have, you feel the big, large ball of stool, it's actually all from chronic constipation that they've had for the last several years. When you're doing your exam, okay, you're doing your single digital exam, it's recommended to come in, and then you gotta think about anatomy-wise and where these different structures kind of insert into the pelvic area. So you come in, you sweep your finger over to one side and come around, you feel the muscle on that side, come to the anterior, the top portion, come down to the bottom by the rectum, and then go over to the other side. So really you're going to be doing that kind of a 360, but you're specifically pushing in those areas where the muscles insert to try to identify if they have something else causing trigger point issues, which would be causing their chronic pelvic pain. And then some specific things you want to think about, things like pelvic adhesions. Okay, pelvic adhesions, this is actually a picture of the uterus. So this is the uterus, and all of these fibrous structures is scar tissue that is just holding, like that's suspending the uterus in midair. Okay, you think that would probably cause some pretty significant discomfort in these patients, especially every time, probably dyspareunia as well, not only just pelvic pain. So this can occur in about a quarter of patients that have chronic pelvic pain. There's also something called pelvic congestion syndrome. These patients will usually have more of they don't come in with like sharp pelvic pain, it's more of this constant achiness or heaviness that they feel in their pelvic area. And it's usually due to congested vasculature. Okay? The veins themselves get swollen, it's like varicosities, but they're on the inside. So higher rates for this is seen in patients that have never been pregnant, usually, higher rates are seen in patients that have history of pregnancy, and then usually it gets better after menopause. Sometimes you will see associated varicosities in the upper thighs. Externally, you might see some varicosities, or even the buttocks. Now, the treatment, of course, is going to depend on what the underlying etiology is. If it's adhesions, they need to have surgical evaluation. So obviously, on physical exam, you're not going to be able to identify adhesions, so you're going to try to rule out all the other causes. And then ultimately, if you can't identify the cause, you would refer them to the specialist. If it's pelvic congestion, so they're complaining about that ache, you actually see varicosities externally, sometimes these patients warrant a pelvic MRI. One of the very few times I've ordered a pelvic MRI is when I saw a patient that had pelvic congestion. And then these patients can be referred for different types of treatment of those vasculature. Sometimes they'll do like a vein embolization for these patients. If you're not really sure what the cause is, then start from the beginning. You got your history, you got your physical exam. Let's try some anti-inflammatories. Let's try some acetaminophen to see if that helps. There's nothing wrong with trying these patients on antidepressants as well. There's a lot of times they have other comorbid diseases. So SSRIs, SNRIs, TCAs, or even gabapentin. I love gabapentin. It's great for a lot of different things. If they have associated dyspareunia or dysmenorrhea, you can even put these patients on, contraceptives, progesterone only or combined oral contraceptives tend to help relieve some of their associated symptoms. Pelvic floor physical therapy, again, for all of these, we recommend pelvic floor physical therapy, and that is just sending a consult to physical therapy, and they talk to them about the referral. Please assist with pelvic floor strengthening, and they'll figure it out. And then obviously, if you've done that, it's been 3 months or 6 months, and the patient still has no improvement, despite your analgesics, anti-inflammatories, maybe try them on a contraceptive, and that's not working, then I would refer them to the GYN for further evaluation. All right, so we're going to go into pelvic organ prolapse. Man, we're moving right along here. Pelvic organ prolapse. What is this? Is this going to be a painful Probably not, right? This is gonna be more associated with that weakening structure. So that being said, we're gonna probably see this in patients that are a little bit older in age. If you have weakening of the connective tissue, weakening of the musculature, then we don't have the support structures that we need for the pelvic organs to stay in place. And so the bladder can prolapse. And when we talk about prolapse, we're not talking about the bladder prolapsing through the urethra. We're talking about the bladder coming through the vagina. Okay, that's a cystocele. The rectum can prolapse, again, not out the rectum, but in through the vagina, rectal seal. The bowel can come right straight down and come out through the vagina, and that's an enteral seal. And then the uterus. When people say, my uterus is falling out, that's literally what it does. It goes right straight down and comes out through the vagina. And that's called prostatitis, or most times it's here coming in the last. This is the third most common cause of hysterectomy. Even if these patients don't have a uterine prolapse, they will often do a hysterectomy because they feel like if they remove the uterus, then they'll have a lot less pressure on the surrounding structures. It's the third most common cause of hysterectomy. And for patients that have pelvic organ prolapse, they have about a 12 to 15% chance of needing some sort of surgical intervention at some point in their lifetime. So again, if we look at these pictures here, and this is normal anatomy. Here, this is a cystocele, and what that has is that the bladder is here, and it's coming down through the anterior portion of the rectum, or of the vagina. Rectal seal is going to come out down to the posterior portion. We feel a bulge at the posterior. The uterus is coming right straight down out of the vagina. And same thing with an enteral seal. The bowel itself, the small bowel is coming down through the vaginal vault, the vagina, the whole vaginal vault can come down and prolapse out as well. And that's a terrible sight. So why do patients get this? Why do they have so much weakening in their pelvic muscles? Childbirth is one of the main causes. Okay? And not just one, and that certainly increases the risk, but every single pregnancy, every single childbirth increases the chance of these patients having pelvic prolapse. Especially if they have to have something like a forceps delivery. When they do forceps delivery, the head is stuck in the vaginal canal. They're taking the forceps, so they're making the vaginal, entrance even wider to put the forceps in there, putting a lot more tension, a lot more stress on the musculature. Episiotomy, you're cutting through the musculature. Again, once you cut through something, it'll heal, but it's never quite as strong. That increases your risk. Age, unfortunately, because it's associated with decreasing estrogen as well, increases your risk. And anybody that has a connective tissue disorder like Marfan's or Ehlers-Danlos syndrome, those patients are increased risk. Hispanic and Caucasian women tend to be a little bit higher risk than if you compare it to the risk for Asian and Black females. Anything that causes an increased risk or increase in abdominal pressure. So something like COPD, chronic coughing. Every time you cough, you have an increase in abdominal pressure. That increases the risk. Higher BMI, repetitive heavy lifting, you can see, especially in the military. And then patients have chronic constipation. They usually have chronic dilation of the rectum, and that's going to constantly push on those surrounding musculature. So a lot of risk factors for pelvic organ prolapse. Okay. So again, we think about a cystocele. So that's associated with prolapse of the bladder, and that's usually due to weakening of the anterior vaginal wall. These patients can come in complaining of symptoms like urinary frequency or urgency, or again, urinalysis negative for infection. They oftentimes will also complain of vaginal fullness or lower abdominal pain, and many times they will feel some sort of bulge that's coming out from the vagina. It's going to be on the anterior. So when these tend to get a little bit larger over time, These patients, sometimes in order for them to urinate, to pee in the toilet, they'll actually have to do what we call manual bolstering. They'll have to take their hand and kind of lift up the perineal area so that they're able to pee in the toilet. Otherwise, the urethral angle changes because you no longer have the muscle that's holding the urethra tight, and they'll go to pee and they'll pee that way or they'll pee that way. Okay? So if they come in and say, like, I don't know, I have the hardest time peeing in the toilet, and I gotta kind of hold things together, that's also an indication that this is probably a cystocele. The problem with cystocele, well, actually the problem with all of these is when you go to look, and a lot of times when we do our examination, we forget to do an external examination first. Do your external examination. Have them bear down during that external examination to see what comes out and where it's coming out. Because if you wait and you try to do it once the speculum is inserted, what is that speculum doing? Supporting the structures. It's supporting everything. So the bulge that was there is now gone because now you're supporting the structure. We have rectocele. So patients that have rectocele, they're going to have a bulge on the posterior portion of their vaginal wall. And again, sometimes they'll have some fullness, sometimes they'll have a mass, they'll have a sensation. They try to go have a bowel movement, but it seems like it's stuck. It seems like they can't have a normal bowel movement unless they do something like a manual bolstering. Again, they'll take their hand, they'll pull things up, and they will have to kind of realign things in order for them to go to the bathroom normally. Sometimes they even have to use their finger to be able to remove the stool because they can't have a bowel movement without doing that. All right, let's take a break and then we'll finish it. Going right down to the middle of the vagina, so down, straight down. Those patients, again, pressure, they may complain of dysphonia, so pain with intercourse. They might complain of urinary symptoms as well, depending on where the bladder or the uterus is, how big the uterus is, what's causing it to come down. It might push on the bladder, so they may have urinary symptoms. And then if it continues to drop down, it actually can cause urinary retention because it's pushing completely on the urethra, surrounding urethral structures, so the urine can't come out. So these guys may say, I'm trying to pee, but I can't. And then you think, oh, it must be a kidney stone. If you're not having any flank pain, so think about things like uterine. So this bottom picture here is this is the uterus that's coming out of the vagina. So I've got to tell you this story about Dr. Cashmere. And so she may have told you, she was one of my students. And we had a patient, so this is when BAMC was not as big as it is now. She was in a trauma, and I was out in the main area, and I heard over the radio that a lady was coming in via ambulance because her pacemaker was falling out. I said, oh, okay, that'd be good. So go in the trauma, and I'm like, come see this patient. And she's like, what's going on? I'm like, figure it out. So she goes in, she talks to a lady, it's a lady and her daughter. And they probably have two teeth between them.
Oh, yeah.
They're just very unique people. And talk. What are you here for? I'm a pacemaker, falling out. Okay, so when did you get that put in? Oh, it's been in there for a while, it's just falling out. So she's like, ma'am, you don't seem to have a pacemaker. She said, yeah, it's falling out. She's like, okay, tell me, like, where are the symptoms that you're having? And she said, down there, it's falling out. So Cashmere looks. She looks in the back. Not there, the front. It's not. She says, the why work? It's falling out. She said she opens up the, because back then we did a curtain, opens up the curtain. She was like, you got me kidding me. And they said pacemaker, I don't know. So ultimately, she figures out that in fact it was not her pacemaker. It was her pessary, which they use for uterine prolapse. So she says, yeah, it's falling out. She said, but I use this finger right here. I push it back in there, but then it comes out, and I push it back in there. And it was just like, ew, first of all. But also it was so funny. I was sitting on the outside of that curtain, and I thought she was going to strangle me to death. She had two crazy people. And she's got to deal with this lady. And she's like, you know, I guess I got to call OBGYN. I don't know nothing about no pessary. I'm like, I don't know anything about pessary. So I guess maybe it was her uterus required. I was like, pessary? So her version of the story is slightly different than mine, but mine is the true version. But no, it was super funny. And I really, because I have seen people with their pacemaker falling out. And it's a really good patient because literally their pacemaker is half in their chest and half out of their chest because oftentimes they've lost a lot of weight and it becomes very pronounced and then it just kind of erodes through the skin. And that's really the case. Pessary falling out, that's not so much the case. We have enteral seal. And that is the intestines. Again, the small intestines are coming down through the vaginal opening. Again, these patients, pelvic fullness, they may have dyspareunia, low back pain. And then oftentimes we talk about low back pain, it's primarily when they lay down, which is unusual, right? Usually you have low back pain, you lay down, it makes it better. For these folks, it actually tends to make it worse. So what do? We got to do a history. We got to, of course, do their physical exam. And there are a lot of different questionnaires out there, but one of the primary ones we use is this pelvic floor impact questionnaire. And it helps us identify the severity of the symptoms that these patients are having. Does the person need a consult or a referral for me to put in today? Can I do some other conservative measures and have them come out and see me in 4 to 6 weeks, or what do I need to do? You want to make sure again that you do that pelvic exam, but when you do your exam, do an external exam first. Have them bear down and look to see if you have anything that is relevant. Usually this is done with the patient in the, with their feet in the stirrups in the lithotomy position. And then again, rectovaginal exam is really important on these patients to try to identify, rectal seal from an enteral seal. So rectal seal can be kind of down the middle or posterior, and then rectal seal is completely posterior. So you want to try to identify the enteral seal from the rectal seal. And then once we do identify the prolapse, we want to try to identify the degree or the amount of organ prolapse that is occurring. We use a system called the POP-Q system, and we grade from 0 to 4 on how much that organ is protruding out past the hymenal area, so kind of on the inside, the vestibule area, so past that. So if we look here in A, we can see this is what we call considered a stage 2. So this is 1 centimeter past the hymenal area. Here in B, we can see this comes out pretty good. And this is usually once that patient bears. So you have to be careful. Before I do this exam, I'm trying to figure out from the patient, okay, how much is going to come out? Like, tell me the extent of your signs and symptoms. Because if you have them bear down too heavily, your uterus will pop all the way out. So make sure you kind of get a better understanding before you do your physical exam on how significant the amount of bulging is that they feel. But this 2 centimeters, and then this other one, this is a uterus is completely collapsed, right? Because what is this? This is your cervix here. So the cervix, the uterus is completely prolapsed out, and that's a stage 4. And now, can you put that back in? Yeah, oftentimes you just put that in. You use a little bit of pressure, push it back in. This is a person that probably needs, they don't need surgery today, but they probably need a referral. It's probably physical therapy, pelvic floor physical therapy is probably not gonna fix this problem. If they can undergo surgery. Some of these patients are much older, they have a lot of comorbidities, they can't even undergo surgery until we think about other treatment. So the ultimate goals, we have 3 main goals for this. We want to increase support, that's done by strengthening the pelvic floor muscles and the structures surrounding the organs. Kegel exercises, pessaries will work for that as well. We want to make sure we decrease strain, and that's by encouraging healthy lifestyle, exercise, weight loss if needed, reducing that heavy lifting, and then if they have chronic conditions like asthma or COPD where they're constantly coughing, we want to make sure that we optimize the medications that are needed to reduce the signs and symptoms associated with those chronic conditions. We want to help avoid getting prolapse altogether. So tell patients, when you're going to have a bowel movement, don't sit on that toilet forever. You know, you should have fairly regular bowel movements, and if you're not, then let's look at some diet modifications that may help with that. Okay, minimize the amount of straining that they're having while on the stool. Use a little toilet stool, right? You know what I'm talking about? Y'all know what I'm talking about. A little toilet stool. Yeah, everybody's got one. I got one in the motorhome, I got 3 in the house, I got it everywhere, right? So you use a little toilet stool, so when you go have a bowel movement, your feet go up on that toilet stool, and it changes the angle, so you have a lot less pressure on the levator ani muscles and the support structures. That just changes the angle. And then for those that already have prolapse, we think about bolstering. Okay? So try to hold up the pelvic floor and hold up the structures to allow them to be able to urinate without having to have bowel movements in normal condition. We all, like I said, I think most of you guys know about Kegel exercises. We'll talk specifically about in a minute. But this is a specific type of Kegel exercise called the neck. And what we're trying to do is kind of more of a well-timed Kegel exercise. Instead of doing it all throughout the day, if someone feels like they're going to cough or sneeze, they tighten up their pelvic floor muscles, and they hold that all the way through that cough or that sneezing. So ideally, it's going to be held for several seconds. And what that does, you can see in the pictures here, what that does is it forces some tightening of those pelvic floor muscles, so it helps reduce the symptoms associated with pelvic organ prolapse, and also a lot of times these patients will have a leakage of urine, have some incontinence associated with it. So it will tighten up the muscles around the urethra as well, and reduce the amount of pressure that we're having on the bladder and the urethra. And these patients will have decreased episodes of that incontinence. And then pessary, see, 3/4 of gynecologists recommend that it's one of the first line treatments is a pessary. So pelvic floor muscles, we start talking to patients from 30 on up, we should be talking about these pelvic floor strengthening Kegel exercises. But if these patients are coming in, they already have a degree of prolapse, then oftentimes, in addition to those exercises, we'll do this pessary. Now, there are pessaries now that are available over the counter that these patients can get, and then if not, they have to be fitted. So you'll send them to OBGYN, and they'll fit the pessary, and then they'll order it, and or they don't order it, they have it in the office in different sizes. Put it in there, figure out the right size, and then they send it. But over the counter, there's a couple of the Impress and the Aresta. Those became available in the last year and a half or so, so patients can use that as well. And all that does is go in and it really, if you look at this picture, you can see what it really does is holds up the uterus. So even if this is not uterine prolapse, if we keep the uterus where it's supposed to be, it will not push on those other structures, okay? And it won't cause prolapse of those other structures, or at least reduces the prolapse. In general, it's going to depend on the type of pelvic organ prolapse they have, and also the severity of their symptoms, their age, their chronic comorbidities. What if they're willing, if they can undergo surgery or not. All of those things will have an impact on ultimate treatment. So pessaries tend to work really well. Most people can tolerate that, no problem. Then they're not latex, so they can use those. If they're postmenopausal or perimenopausal, topical estrogen can help. And then Kegel exercises are going to be one of the mainstays for these patients. Ultimately, if those things don't help, then some sort of surgical intervention can be done as well. All right, and then we'll finish up talking about urinary incontinence. Urinary incontinence, okay? This is another cause of the weakness of those pelvic floor muscles. And really, when we think about, say, urinary incontinence is just involuntary leakage of urine. In fact, up to 60% of women and a big portion of men as well. Okay? Oftentimes increases with age and can increase depending on patients' associated comorbidities as well. There's a lot of different factors that increase someone to have incontinence, obesity, smoking, heavy lifting, anything that affects the pelvic organs can also cause incontinence. And then other things you want to think about, things like medications as well. But in general, we have age-related changes of the bladder. And that can cause different degrees of this incontinence or different degrees of overactive bladder as well. Sometimes we'll have what we call detrusors. So detrusors, the bladder muscle, we have overactivity of that. We have decrease, as someone gets older, they have decrease in bladder capacity, so the bladder just can't hold as much urine as it once does, which makes it so these patients have to use the bathroom more frequently. The majority of women over the age of 50 will tell you they get up at least once in the night to go to the bathroom. And that probably increases every, 60 is 3 to 4 times, 70 is 4 or 5 times. So you're not getting a tremendous amount of sleep from the fact that you get up to go to the bathroom quite a bit. Okay. The other thing is these patients that are perimenopause or postmenopausal, because of that decrease in estrogen, they're going to have atrophy of those surrounding connective tissue and the surrounding musculature. That predisposes them for things like stress incontinence, so when they sneeze or cough, they can have leakage of urine, or even urgency, where they feel like they got to go to the bathroom all the time. So we've got to get a good look at their medical history, a good look at the medications that they're on as well, because sometimes it's a medication that's causing that. If you have somebody that is on HCTZ, okay, hydrochloric acid, what does that make you do? Makes you pee. With Lasix, it makes you pee. Okay? And so those things, if they're on those medications, they can have a degree of incontinence because they're trying to get to the bathroom so quickly, but they just can't get there enough so they can have some incontinence. So look at their medications and see if anything's related to the medications. Do your physical exam, okay? Or should include a GU exam, maybe a GYN exam in these patients as well. Feel around the urethra, around the base of the bladder. Rectal vaginal exam should be considered, and even a neuro exam, because people can get neurogenic bladder. So you want to feel in the perineal area. Do they have any numbness or tingling in the perineal? What about the lower extremities? Do they have good sensation in the lower extremities? I typically will do a full cranial nerve test on these guys, and I will often do a cerebellar test on them as well. So medications, again, there's a lot of medications that can lead to urinary incontinence. You don't need to memorize these, but we know in general that medications have side effects. And some of the medications that we put our patients on can contribute to them having incontinence. So we're going to take a look at those medications. And we want to do an assessment again, just like we did with pelvic organ prolapse, is we want to try to identify the significance of this patient's urinary incontinence. So there's a lot of different questionnaires out there. You can choose whichever one you want to use. But most of them ask the same amount of questions. So, how many avoids do you have during the day or night? Are you using any sort of pads, urinary pads? And if so, are they completely soaked when you change them? Or How often do you have to change them? And what about quality of life? Is it impacting your daily quality of life? So some people have incontinence so bad they can't even go out and go to the store. That's because it bothers them so bad. So just oftentimes I'll have my nursing staff, my medic, have them fill out this questionnaire first, bring it to me so that I can review all the answers. It gives me a good idea of where do we go next from this? What is our next step based on the severity of the signs and symptoms that they're having? And then, in addition to answering those questions, we often recommend the patients to avoiding diarrhea for 3 to 7 days or so. Here they're going to split down, okay, what is their intake, oral intake, how much are they intaking, how much are they peeing per day. Oftentimes I'll send them home with a toilet hat so they can pee and they can measure it, and then they write all of that stuff down. How many episodes of urinary leakage did they have in that time period? Were there any specific triggers of the incontinence? Or did it occur after coughing? Did it occur after sneezing? Was it because they couldn't get to the bathroom in time? Was it because the water was running and it made them feel like they had to go to the bathroom? All of those things are annotated on this diary. And then once they complete that, so usually I'll have them come back and see me in a week. This can help you try to figure out what the cause of their incontinence is. So there are different things that we think about for incontinence as the different causes. For diagnostic study, of course, urine and urine culture is typically something that you're going to do from the primary care standpoint. Post-void residual can be done as well. If you have either an ultrasound or a bladder scanner. If you have an ultrasound, you got to know how to assess the bladder with the ultrasound. Use it in 3 different ways to assess the bladder, and then they'll give you a spit out of how much urine is left in the bladder. Typically for post-void residual, we're looking at should be less than 100 mL. And then urodynamic studies, that is done by urology. So we refer the patient to urology for urodynamic studies if that is needed. Other reasons that we'll refer is, obviously if they have hematuria, if they have reoccurring documented urinary tract infections, that would be unusual. If they have persistent symptoms, especially in people that are history of smoking, is an increased risk of bladder cancer. If they have associated pelvic prolapse with this, especially if we're talking about a grade 3 or a 4, or if they have chronic pelvic pain, those are reasons to consider referral these patients. There are some patients that can have transient causes of incontinence. We use this mnemonic diapers, although that's not a nice mnemonic for these people, to help us identify these transient causes. So delirium. They're acutely confused. So sometimes we think about delirium like urosepsis. And so they are septic because they have a urinary tract infection. But most of the time, you're going to see this more often in hospitalized patients. A lot of these patients are in nursing homes, and they're going to bring them to you because they're constantly losing control of their bladder, and the nursing staff is concerned maybe they have an infection. And then, of course, urinary infection itself, especially in older patients, causes irritation in the bladder, so they can no longer hold the urine in the bladder, and so they'll have leakage of urine, which is why we do our urinary culture. Atrophic vaginitis, if they have urethritis for men, that can cause it. Could be medications, could be a psychological component of it. We had a young girl, she was like 19, with constant problem with urinary incontinence. Then ultimately she couldn't pee at all, and it was all she ended up having a catheter for months and months and months. All was psychological, all of the little young basic training here. So sometimes that is the case. So do a really good history on these patients and figure out if they personally have a history of psychological disturbance or if they have a family history of psychological disturbance. If they have endocrine restricted mobility, they just can't get to the bathroom in time, and that's really the cause of the urinary incontinence. And then stool compaction, so constipation. If the rectum is enlarged from the bowel, we can push the structure up, so it's pushing and irritating the bladder. and that can cause these patients to have incontinence as well. Oftentimes, if you do a disimpaction, then these patients will urinate normally. Those are always fun. I'm sure in phase 2 you'll get to experience that manual disimpaction. I hope you do. Everybody should do it at least once. At least once, right? We used to do them all the time. We don't do them as much as we used to do them all. I mean, I can't tell you how many manual disimpactions I do in phase 2. Like it was all the time. PA student, you go in and do it. I'm like, oh, go in there and do it, and it's terrible. It's terrible for the patient. All right, let's talk about some specific incontinent types. Stress incontinence, so that's a leakage of the urine when the bladder's under stress. Increased intra-abdominal pressure, so coughing, sneezing, laughing, even things like running can cause that. Most of the time it's just a dribbling, a little leakage of urine, and not typically associated with complete loss of urine or bladder contraction. Directly related to weakness of the pelvic floor structures or even weakness around the urethra. We have a change in the urethral angle that's causing this. Urethral hypermobility can occur as well, which can be from decreased estrogen, or it could be from some prior surgery that these patients had. There are degrees of incontinence where a patient will come in and say, degree 1, only if I cough or sneeze pretty hard where I have leakage of urine, or you can have people that I'm just standing here, and if I just bear down, I'll have leakage of urine. So grades 1, 2, or 3 are kind of degrees of urine incontinence or stress. Okay, so on a normal basis, okay, if someone has decreased or downward pressure on the bladder, increased intra-abdominal pressure, downward pressure pushing on the bladder, the muscles around the urethra are going to come in, they're going to tighten around the urethra, and they're going to prevent that leakage of urine. But when the musculature or the connective tissue around the bladder is weak, we get that downward pressure from the abdominal cavity, and it changes, it pushes the bladder down, and now changes that urethral angle. When it changes that urethral angle, the muscles can no longer come in and kind of protect and close off that urethral, the bladder neck essentially. So these guys will have leakage of urine. So that's what we talk about for urethral angle. It changes the closing pressure. Conservative management for these patients is typically what we're going to do initially. We generally talk about pelvic floor strengthening with our Kegel exercises. They can do what's called passive electrical stimulation. And so what they'll do, this is usually done by physical therapy or Urogyne. And they can do a vaginal probe, and it has this electrical stimulation. They're trying to stimulate the muscles to fire and strengthen the muscles up by doing that. Again, topical estrogen can be considered, pessaries can be considered, especially in the event that this urinary incontinence is due to pelvic organ prolapse. They can do periurethral collagen injections, which will tighten up the muscles as well. And then the most common surgery that they'll do is a sling surgery. They'll go in and they'll put a sling around the urethra, pull it up, and then what they often do is they'll take these 2 strings and they'll put them outside of the inner portion of the patient's thigh, and over time they'll have the patient come back in a couple of weeks, and if needed to, they'll actually tighten up the strings. If they're still having incontinence, they'll tighten up those strings. Once they get the right amount of pressure around the urethra, then they'll cut the strings off and they'll sew it up. Pretty interesting. Kegel exercises. So what are they? What do we do? So they strengthen up the liberating muscle. That's the main thing we do. We typically recommend these patients do this all throughout the day. Don't need to get up in the middle of the night and do them 50 to 60 contractions throughout the day. And we have this isotonic where they can hold it for 10 seconds. We start with 3 sets and we work all the way up to 10 sets. Usually they hold it for 10 seconds, wait for 10 seconds, hold it for 10 seconds, wait for 10 seconds. Episodes, or do 10 of those and then repeat episodes. This, over several weeks, if we can get these patients up to doing 10 sets a day, Usually within 4 to 6 weeks, they'll already see an improvement of their urinary incontinence. They also have this isometric version, and they use this for some patients because some patients will come to you and say, well, I don't know, I do those Kegel exercises all the time, but I don't feel like I'm doing anything. I don't really know if I'm doing it right or not. So what they will do is they'll actually, it's kind of they'll use this cone kind of dilator, if you will. And when they do the Kegel exercise, and before they do them, they'll insert this into the vagina, and then they'll tighten it around it, and that way they feel, they can tell if they're actually doing the right exercise or not. Because a lot of times people don't do Kegel exercise correctly. They tighten more their rectal muscles, or they tighten their abdomen, but they actually don't tighten the letter anal muscles, so they actually have to tighten more of their perineum. So sometimes that can be difficult, so they'll use these vaginal cones to help them figure out if they're doing it correctly, and they can do that. That's for stress. So stress incontinence, cough, sneezing, they're gonna have a little bit of leakage of urine, urethral hypermobility, or change in the urethral angle. Urge incontinence is a little bit different. Right? Here, these patients have this sudden, strong urge to urinate. The bladder squeezes, or the bladder often will spasm, and then that results in these patients having incontinence. And that incontinence can range from a few drops to complete loss of bladder control. And this is typically caused by the bladder muscle itself is unstable. We get these involuntary contractions. Usually it's from, either they're washing their hands or water is a common trigger for these patients. And the bladder muscle itself is strong, it just gets these spasms, and that's the spasms are what causes the loss of the tract, or the loss of bladder control. We treat this similarly. We still do the Kegel exercises, but for these patients, we added this thing called scheduled voids, or bladder training. We're trying to retrain the brain and the bladder to work together. And so what happens is, for these patients, we start off by every hour, whether you feel like you gotta go to the bathroom or not, you're gonna go. And then we push that up. Every 2 hours, you're gonna go. Every 3 hours. Ultimately, we wanna get that to the normal time period of every 4 to 6 hours, you're gonna go and use the bathroom. We're retraining the bladder, retraining the brain as well. And you can use medications, things like anticholinergics. What's the problem with anticholinergics? All the things, right? Dry mouth, dry skin. There's a lot of side effects. And so most patients can't even tolerate the medications for a longer period of time because of the side effects associated with it. But if we're going to use medications, oxybutynin, tolterodine can also be used. But we got to remember, if we put these patients on these medications, to talk to them about the side effects, and one of those including blurred vision, because otherwise they'll come back to see me and say, I can't see, and it dries the eyes. Again, this is that bladder training. We're going to train the brain, and we're going to do that by starting off, go to the bathroom, even if you don't feel like you have to go, every 2 hours, and have them keep a log. And then have them come back and see you in a week. And a week from now, see how they've been doing. If they can increase it every 3 hours, that's what you're going to do, ultimately to the point of having them go back to the normal time period, to 3 to 4 to 6 hours. You can have mixed incontinence. Here is a combination of that stress and urge incontinence. You guys get still. When I cough, I urinate a little bit, but I also frequently have the urge to go to the bathroom. If I hear running water, I'm washing my hands. Treatment is going to be a combination. When you do your Kegel exercises, we'll also incorporate some bladder training in here, and then medication, something like imipramine actually works better for mixed incontinence than the other medications do. If someone has an overactive bladder, okay, so overactive bladder, for these patients, it's kind of interesting because their bladder, they do have this involuntary contractions of the bladder muscle, but they don't always have incontinence. They can feel bladder spasms, but it doesn't necessarily lead to incontinence. So sometimes it does, sometimes it doesn't. Sometimes they'll have increased in daytime frequency, and a lot of times will have increase in going to the bathroom more at night because their bladder tends to, they say my bladder wakes me up at night for these patients. So oftentimes, again, they may or may not have associated urgent incontinence, but they usually have increased daytime and bacteria from the involuntary contractions. For these patients, we also incorporate cable, but bladder training, and then the oxybutynin can work for these patients. If that doesn't work, sometimes they'll do, because it's contractions of the bladder, they can do Botox injections around periurethral or around the neck of the bladder, and that will help with the spasms of the bladder. And then we have incomplete bladder emptying. This is formerly known as overflow incontinence. So here these patients have the urge to urinate, but when they go, they only go a little bit. So then an hour later, they go back, and then they only go a little bit. So the bladder is not emptying like it's supposed to. So the overflow incontinence is that the bladder gets really, really big, full of urine, and then they just pee out a little bit, enough to decrease the irritation in the bladder. Then an hour later, they feel like they gotta go in because the bladder is still full of urine. Okay? When it gets too full, then the urine leaks out a little bit, and so this is a constant cycle. The problem with incomplete bladder emptying is because that urine is held within the bladder, it significantly increases these patients' risk for frequent urinary tract infections. They have all that bacteria is kind of hanging out in the bladder. This is a good patient that's coming in that you really, it's important for you to get that post-void residual because they have retained urine. Now we got to figure out why. Is there something compressing the spinal cord that's causing this, or some neurologic disease? Do they have some sort of pelvic surgery and they affected the nerves in the pelvic region? Again, is it some sort of medication that they're on? Medications like calcium channel blockers or alpha blockers, it is not uncommon for those who cause some problems for overflow incontinence or incomplete bladder emptying. So if they are on calcium channel blockers or they're on alpha blockers, then the recommendation is probably take them off. And that's usually used for blood pressure and put them on a different blood pressure medicine, see if that solves the problem. Otherwise, these patients are going to have to do intermittent catheterization. They've got to get that urine out. And so that every time they catheterize themselves, that also increases the risk of urinary tract infection. And then the Benecol, sometimes that can be used fairly successfully in these patients. But the biggest problem with incomplete bladder emptying is trying to figure out why. Why are they having this? And that's going to be the longest part. Is you may order imaging of the back, from plain films, CT to MRI. They may need CT of the abdomen and pelvis to see if they have some sort of tumor or something that's growing. These patients tend to need a lot more of a workup than the other patients do. Functional incontinence, I just can't get there in time. My knees hurt, my back hurts, my hip hurt. I can't get there. I try to get there. So how do we treat those patients? Let's manage their underlying comorbidities. Okay? Let's make sure that they're on the appropriate medications for their underlying knee and back and hip problems. Ultimately, talk to these patients about wearing undergarments that have the urine pad in them. And if you need to, send these patients to physical therapy. Physical therapy can help not only with their chronic comorbidities, but also they can work on doing some strengthening of the bladder muscles as well. So dietary changes, we talk to our patients about decreasing caffeine, decreasing alcohol, decreasing our acidic food, because we know that they can trigger not just urinary incontinence, but think about interstitial bladder syndrome. Okay, that can trigger those symptoms associated with that as well. Okay, there's this medication called pre-leaf. In pre-leaf, we add it to food or add it to their drink oftentimes, and that helps buffer, change the acidity of the urine, and sometimes that will help with these patients' symptoms, weight loss, smoking, and then controlling their chronic medical conditions as well. Okay, so a general approach that we have for urinary incontinence, and we want to think of this as a lot of these patients, it really affects their quality of life. So we want to manage these patients fairly aggressively. But we want to start with behavioral modifications. Behavioral modifications like diet, weight loss, and stopping smoking or decreased smoking works for all of the kinds of incontinence. Look at their comorbidities and see if you can address those comorbidities. Someone that has asthma and they have frequent attacks, but they're not on inhaled corticosteroid, maybe you want to add that. Maybe for these patients, again, they have functional incontinence, so I was talking about sending them to physical therapy. So behavioral modification will be next, bladder training, Kegel exercises, doing the nap. Okay. After that, then we go to medications, because those medications have a lot of side effects. And once you're out of that realm, we'll be referring these patients to some sort of surgical intervention, which we need done for all three of these causes of incontinence. Ooh, we did it. All right, thank you.